Hey everyone, let's say that you are on call and a new patient is admitted. This is a 45-year-old female with a newly diagnosed ALL. Her white blood cell count is under 50,000. She's a bit dehydrated but stable for now. Chemo is scheduled to start in the morning. Now pause and ask yourself, what would you be most concerned about in the next 24 to 48 hours? What labs or clinical signs would you be watching closely for this patient? For this patient, while the cancer is the long-term problem, the immediate danger isn't the leukemia itself. It is going to be what happens after we start treatment. This is where we need to be thinking about tumor lysis syndrome, the classic oncologic emergency that can quietly evolve into a crisis if you're not ready for it. Tumor lysis syndrome can occur when cancer cells die off very quickly, usually after starting chemo for fast-growing cancers like some leukemias or lymphomas. We're going to be killing the cancer cells with the medications that we are giving, and once the cancer cells lyse or break apart, they're going to be flooding the blood with substances like potassium, phosphate, and uric acid, and these substances are going to be coming out of the cell as they get broken apart, and then they release the intracellular contents of the cell. Now, this sudden overload of the substances is going to be throwing off the body's homeostasis, and it can cause dangerous problems like abnormal heart rhythms, seizures, as well as kidney failure. People most at risk include those with very high white blood cell counts, over 100,000, high LDH levels, which is a sign of fast-growing cancer, large tumors over 10 centimeters, as well as kidney problems before treatment, and high uric acid levels before chemo. Certain cancers like Burkitt lymphoma, lymphoblastic lymphoma, and CLL treated with venetoclax are known to trigger TLS more often because they respond so strongly and quickly to treatment. People with moderate risk, like some AML patients, still need careful monitoring and preventative steps even if they don't need the strongest medications right away. How is tumor lysis syndrome diagnosed? We're going to be using the Cairo-Bishop criteria to diagnose TLS. Now, there's two categories of TLS. One is going to be lab TLS, and the other is going to be clinical TLS. Lab TLS is when two or more key blood levels like uric acid, potassium, phosphate, or calcium cause certain thresholds or change quickly within 3 days before to 7 days after chemo. The key blood levels that we need to be monitoring in tumor lysis syndrome are going to be, again, uric acid, potassium, phosphate, or calcium. Now, if you need a mnemonic to remember these, then you can use the mnemonic PUC calcium. P is going to be for phosphorus, U is going to be for uric acid, K is going to be for potassium, and of course calcium is going to be for calcium. On the other hand, clinical TLS means there are serious complications like kidney injury, where the creatinine is going to be 1.5 times the normal, as well as seizures or heart issues like arrhythmias. And this is when things for the patient becomes life-threatening. In order to catch this early, we need to do a lot of blood work. It is recommended that we do every 4 to 6 hours, and we need to monitor the patient's heart. We need to have the patient on constant heart monitoring for the first 1 through 3 days after starting treatment. How do we prevent and treat TLS? Hydration is going to be crucial. We need to flush the kidneys with plenty of IV fluids, about 2 to 3 liters, and this is going to help the body get rid of the excess waste. If fluid builds up too much, we may also add a diuretic to help the patient pee more. We also need to lower the uric acid. We can use allopurinol, 300 to 600 milligrams per day. It is going to be a medication that is most often used, especially in lower risk patients. Now, it's important to know that allopurinol is going to prevent new uric acid from forming, but it is not going to lower the levels of uric acid that are already in the blood. Rasburicase is going to be the medication that is going to be doing that. The dose for that is going to be 0.2 milligram per kg IV or 3 to 6 milligrams at a fixed dose. It's going to be stronger, and it's going to be rapidly breaking down the existing uric acid. Rasburicase is going to be the first choice of the medication if the uric acid levels are already high, if you can't get enough fluids to the patient, or if the patient is already showing signs of TLS. Now, there's a genetic caution with rasburicase. Some people, there's a genetic caution with allopurinol. Some people, especially those of Southeast Asian or Black ancestry, have a gene called HLA-B5801 that puts them at a high risk of dangerous reaction. Steven-Johnson syndrome is going to be the reaction to the medication. If they have that gene, they should be using febuxetine instead. It is also important to mention that we no longer alkalinize the urine for patients. Raising the urine pH used to be a common treatment option to dissolve uric acid, but we've learned that it can actually make things worse by causing other kinds of crystals to form. So now it is only done if there is severe metabolic acidosis. When it comes to correcting electrolytes, high potassium is treated with emergency meds like IV calcium, insulin with glucose, inhaled beta agonist, or dialysis. High phosphate is going to be treated with phosphate binders like sevelamer. Low calcium is usually not treated unless symptoms like muscle spasms or heart issues show up, because giving calcium too early can cause harmful crystal buildup in the kidneys. Dialysis is going to be needed if these problems don't respond to meds, if the patient's urine output stops, or if phosphate and calcium levels hit critical thresholds. Once TLS progresses from lab abnormalities to actual organ problems, the risk of dying in the hospital is going to double. That is why we need to act early before kidney or heart trouble sets in. Studies show that patients who got rasburicase, proper hydration, and close monitoring early almost never needed dialysis and survived just fine. The main issue in patients who died was that the problem was not recognized early enough, so it is extremely important that we get accurate baseline lab values before starting treatment and identify who's going to be at risk immediately, and we need to start fluids early and aggressively. We also need to use the right meds for uric acid depending on the risk level of the patient. We also need to monitor labs and heart rhythm closely. We also need to correct electrolytes fast but carefully, because in TLS, things can go from stable to critical within hours, so early detection is going to make all the difference.